I'm Chris Granger. I'm here at the American Heart Association meeting with Jamie Jollis, and we're delighted to have just presented the results of the Mission Lifeline STEMI Accelerator program. And Jamie, this was a really very ambitious program and something that we're really proud of as being something that's very important. So Mission Lifeline, which both you and I have been involved with, Alice Jacobs really started it. It's an important national program of the American Heart Association to improve care of STEMI. It's focused on communities, on systems, hospital systems of care, basically on individual networks of hospitals. It's made a big impact on improving timely application of primary PCI, and in fact we have evidence that it also has resulted in improved survival. But what we did in this program with a very talented team, including Mamie Reddick, is to go out and identify regions around the country that hadn't really implemented Mission Lifeline, and to take a regional approach for the first time, really, in this demonstration project. And in fact, we included 16 regions, 484 hospitals, 1,300 EMS agencies, and 23,000 patients with STEMI. So really one of the most ambitious programs ever embarked on in this area. And can you describe the results?
Sure, Chris. It reminds me when we started, this is really what the DCRI is great at. It goes back to the history of DCRI with clinical trials and an endpoint of 60-minute reperfusion. And great organization and working with lots of hospitals, having common protocols, and things really work well. And so here going out 20, 30 years after the original studies in DCRI, we are still doing the same things with that final barrier of care. It's not enough to prove something in a randomized trial. You actually have to implement it for patients. And it's amazing, actually, this far beyond, we're still talking about implementation, but that's what this is all about. So our results, first of all, our main endpoint was looking at the current guideline, which is from first medical contact to device times for patients presenting by EMS or to a PCI hospital of 90 minutes, for those being transferred of 120 minutes. And combining all regions together for every one of these measures, we saw significant improvements in the percentage of patients reaching these guideline goals. And as we look across regions, we actually saw some regions that had up to 20% improvements in reaching these guidelines. So really encouraging results. The other piece of this work, which to me was obvious, but I think it just bears talking about again, is this relation between treatment time and survival. The whole notion that it doesn't matter when you close a coronary artery how long you wait to open it just goes against clinical intuition, goes against the original Reimer and Jennings findings at Duke back in the 1940s of the wave of infarction, and really goes against during my practice in the CCU with a patient who gets reperfused in the first 60 minutes, who goes home 3 days later, and the person who waits 3-4 hours is cardiogenic shock. So we looked at this, particularly this issue, and our measure is what we call ED time, as you know. So from the moment the patient gets to your emergency department to the moment they go to the cath lab. And this actually has very little to do with the ED. It really has to do with coordination between the paramedics and the cath lab, or between the transferring hospital and the cath lab. And if you're working together, this ED time is less than 30 minutes. It gives you plenty of time to get the cath lab set up, pick the patient upstairs. If it's longer than 45 minutes wait time in the ED, that shows a lack of coordination. And probably the most striking findings I've ever seen in survival, for those patients who had ED times less than 30 minutes, we saw a 3.5% mortality. For those who had ED times beyond 45 minutes, the mortality is much higher, close to 10%. Huge differences. Two explanations. One, it's a bit confounded that people who took longer in the ED were busy dying, things like cardiogenic shock, cardiac arrest. But I think more importantly, that ED time reflects that coordination and really is proof of concept that if you can coordinate care between that medic and between that emergency department and the cath lab, patients are treated faster, do better. And that comes out in overall numbers. We look at the accelerated regions versus national numbers. The national numbers look pretty much stable, no change. Accelerated regions, we see numerical drops in mortality.
And that's really important. And Jamie, it's probably worth just re-emphasizing to people that acute myocardial infarction is the acute manifestation of the #1 cause of death in the world. And this average of a 5% improvement in achieving guideline goals for timely reperfusion is something that's really important. And as you point out, as much as a 20% improvement in the regions that really were most successful at doing this. And I do think we have demonstrated that this type of work can make a big difference on improving public health.
And then since we're in the DCRI now, I just want to mention a few other things about DCRI. So this reminds me, typical of DCRI, that Rob Califf had this idea to do this 40,000 patient trial called Gusto. At the time we were doing 100 patient trials. We thought he was nuts. He bit off more than he could chew. And this really changed the care, the whole concept of proving evidence with these mega trials. And then you and I, driving in the car across North Carolina, we spent $1 million in 10 minutes. And we decided to extend RACE to the entire state. And for the next 2 years, we thought this was quite a mistake, but it turned out to be the best thing we ever did. And once again, an accelerator project, we have extended to 16 regions, including New York City, Houston, St. Louis, these huge areas. And again, with a lot of help from thousands of colleagues, has been a lot of work, but aiming high, great results. And it was only an 18-month intervention. Our whole concept with DCRI is to change care, is to build this into the new standard of care. And that's what we've done here, taking the time to change rules, to change protocols, to train paramedics, to train cath labs. And I fully expect as we follow these cities beyond, as well as other cities who copy them, that we'll continue to see improvements, which really what the DCRI is all about, is changing heart attack care. And lastly, I want to say about the DCRI is we have a great team. So you and I are up here getting all the credit, and I know we both worked very hard. We're both here today, just waiting for that extra cup of coffee. But we have a huge team behind us. And as you mentioned, Mamie Reddig, Kathy Fox, Ashley Mitchell, the fellows, Matt Sherwood, who presented today, did an excellent job, and Akshay, who was one of your prior fellows and now is doing a great job, academics, did their background work. Many others. The Heart Association working with all their different affiliates and all their leaders locally. And then every single region, physician leaders in hospitals and administrators and paramedics. It's been an incredible collaboration, typical of DCRI.
Well, thanks, Jamie, for that overview.